And I'd like to introduce the first two speakers of the first lecture. Dr. Gouveia, who is our current EACTAIC fellow. He completed his anesthesiology residency in Lisbon and is currently cardiothoracic and vascular anesthesia fellow here at the OLV clinic. And he's supported by Dr. Buys. She studied in Belgium and worked as a cardiac anesthesiologist in Barcelona, Spain for 8 years. And now currently she's working here at the OLV clinic as a cardiothoracic anesthesiologist. And they will discuss a very important topic, closing the gap between desired versus actual preoperative optimization of the cardiac patient.
Hello.
Good evening.
So we're going to talk about the preoperative optimization of the cardiac patient, and we have no disclosures. I'm going to start the presentation, then I'm going to pass it to Dr. Buys. So being cardiac surgery, the surgical specialty with the most use of blood products, we should adhere to the concept of patient blood management in an effort to improve patient outcomes. So this concept is supported by 3 pillars, which is identification treatment of anemia, blood conservation in the perioperative period, and also optimization of anemia tolerance. So we're going to talk about the first pillar, which is identification treatment of anemia or reduced red blood cell mass. So anemia is defined by the World Health Organization as an hemoglobin concentration less than 12 in women, less than 13 in men. This is a definition that comes from 1958, and it was updated in 1968, and it has been like this ever since. Using this definition, we have a prevalence of 20 to 50% of cardiac surgical patients with that are anemic. In terms of impact in outcomes, we know that anemia leads to red blood cell transfusion, and either red blood cell transfusion and also anemia increase morbidity and mortality. In the case of anemia, there are some studies that say that mortality increases as much as 3 times. Also, both together can have an increased morbidity and mortality, but that has not been proven in more recent studies. So a Dutch study with more than 35,000 patients from 2022 confirmed that anemia is a risk factor for, or increases mortality in the postoperative, and also increases adverse events like pneumonia, perioperative myocardial infarction, transfusion, renal failure, and so on. In terms of etiology, we should be aware that in cardiac patients, anemia is mostly multifactorial. So it can be either from blood loss or destruction or some decreased production. But either way, in any pathophysiological pathway, it ends up being or leading to iron deficiency, which can be absolute or functional. Absolute with depleted iron stores, or functional where the iron stores are good, but the mobilization is insufficient. So we can say that there's iron deficiency in 30 to 80% of anemic cardiac patients, which is a lot. And also in non-anemic cardiac patients, 20% are iron deficient. According to the guidelines, we should screen all patients for anemia and determine the etiology of this anemia. But also this consensus from the ERA Society and the Perioperative Quality Initiative in 2022 tells us that we should also screen for iron deficiency, and not just for anemia, and preferably 4 or more weeks before surgery. And that is because iron deficiency has been associated with lower postoperative hemoglobin, increased transfusion, and increased mortality.